directed towards preventing the overproliferation of T cells to do harm. And when you try to really activate immune responses by the procedures that we use then, they run into that barrier because after you turn on this pathway that we showed was mediated by a molecule called CTLA-4, after that it gives an off signal, because the immune system tries to stop itself. And so the idea that we came up with again in the mid-90s was, rather than trying to turn it on, let's just keep it from turning off. Let's unleash. People talk about harnessing the immune system. And there's ways to do that, but that wasn't what we were concentrating on. What we were doing was trying to figure out a way to unleash it, to let the T cells do what they would have been doing anyway. And the nice thing about what we found was that CTLA-4 was this molecule that shuts off co-stimulation. It shuts off one of the signals that you need to get an immune response started. It works during priming. And so when you take it out of the picture, you do a lot of things, not just allow T cells to keep going, but it lowers, what we know now, it lowers the threshold of signals that you need. So it can bring new clones into an immune response, new T cell clones that weren't there before into the immune response that can help get a multi-pronged effect. And so rather than, the other, the three pillars of immunotherapy, of course, when this work started, were surgery, which goes back to the Egyptians, I suppose, and then radiation with the Curies, and then chemotherapy starting in the after World War II with mustard gases and stuff, and then proceeding through genetically targeted things that hit individual molecules that control cancer. They either attack things that killed cells that are dividing more rapidly than they should, or in the case of the genomically targeted things, a specific mutation, but genomic instability is a problem, as you mentioned, and so it's difficult to think that you could get a cure from that when you had a population of tumor cells that are inherently genomically unstable and have a lot of mutations. They end up with a lot of driver mutations. So the immune system, though, just detects differences. It detects non-self. It detects things that ought not to be there. And so the idea was let's just unleash that power of that system to do what we do anyway. And so what we know now was not necessarily apparent when we started this work, but the immune system properly unleashed can attack not just the driver mutations, as they're called, that the cancer biologist would target, but all of the mutations, including those that used to be called passengers or junk, that doesn't matter. You can turn, you could get a multi-pronged attack just by unleashing the immune system. The second thing is that since you're treating the immune system and not the cancer cell, the immune system doesn't really know in any fundamental way, and this is a broad generalization, of course, a breast cancer cell from a kidney cancer cell from a melanoma, they're different. Melanomas, it turns out, things that are caused by mutations from sunburn or smoking or whatever, are more immunogenic, and which made them harder to treat by conventional mechanisms. But it makes them sitting ducks for the immune system because they have more targets in them for the immune system to go after. And so you don't have to come up with a different drug to treat every cancer. You can treat the immune system itself to unleash it to go after most anything. Now, that was the idea, and it's been realized to a degree, of course, but not completely. Again, those cancers which are caused by exposure to carcinogens are rich with targets. Those that are spontaneous and have other mechanisms in their causality or poorer targets. And so while these immunotherapies unleashing, during priming CTLA-4 or PD-1, which Tosco Hadjo developed with the help of Arlene Sharp and Gordon Freeman, is a molecule that stops fully differentiated T cells. So we have two drugs now that are forming the basis of this approach, one of which works during priming, the other one works on fully differentiated T cells. And when you put them together, it's a marvelous effect. In melanoma, for example, with NSCTLA-4, follow-up studies on 1,000 or more patients, of whom there was 10 years plus follow-up in 2014, showed that a little over 20% of patients were alive 10 years after a single round of treatment, showing the power of unleashing the immune system, giving you a diverse population of T cells to attack multiple antigens. The memory that you get from the memory T cells, that, when you get a T cell response, hopefully, we don't know for sure, but many of them last for the rest of your life. They become slowly regenerating, stem-like cells that can be rejuvenated. And that's where we get curative therapies, which were not possible before. The therapies that existed before then, surgery, radiation, chemotherapy, if you didn't kill every last tumor cell, as you said, you lost. You had to kill every cell. Now we don't have to do that. And because the immune system will figure it out. And the immune system is a living thing. It can adapt as the tumor changes. We've got probably 100 million different tumor cells in our body that can go after stuff. We have to get them expanded. We have to limit that. And so there's control circuits that we found that stop that from being as effective as it might. But we know now how to manipulate those to an extent, and we're still learning. There are multiple, what we call checkpoints, not necessarily a very accurate term, but nonetheless, that's what they're called, which is curative. And in melanoma, for example, where we started, when in 2011, when the FDA approved anti-CTLA-4 antibodies for therapy of melanoma, before then, the median survival after diagnosis with metastatic melanoma was 7 months. And so with anti-CTLA-4 alone, as I said earlier, 20% of people are alive 10 years plus later. There are people now that are 20 years out that were in the phase 1 trial. Now with PD-1, because it works differently, you can combine these two. And the 5-year survival, which is about as far as the data goes now, because that's when the randomized trial was, is close to 55%. And there's no reason to think that that's not going to be 10-year survival. There's no reason to think that the combination is going to be less durable than the individual components. But so that's an example of what we can do. But, as with everything, it's not necessarily quite the kind of success that we would like to have. There are other tumors, as I said, with bladder cancer and kidney cancer and head and neck and a lot of other cancers that respond, but the response rate is less. It's in the range of 30 to 40% or so, or even less. And so what we have to do now is to really look at the microenvironment, because we now know it's not just T cells. It is myeloid cells. It is the whole tumor microenvironment. And so the way we're going to move forward now is by really getting specimens from patients that are on trials, figuring out what the good components are, what the bad components are, and what the type of cancer, adjusting it. Because we know that some of the negative checkpoints that are common in melanoma aren't there in prostate cancer and vice versa. And so it is going to have to be individualized somewhat. And in some cancers like glioblastoma and pancreatic cancer, we're really not that far along. But I'm optimistic that with some hard work and paying attention to fundamental principles and getting biopsies and studying what's going on, that that we will get there. And I think that the other thing that's going to happen, maybe I don't want to get ahead of it, but is to start combining conventional therapies with immunotherapy to really, because right now what we're doing is, I said, CTLA-4 works during priming. We don't know when the priming is going on in somebody that just has cancer, but if we could kill a bunch of tumor cells with the conventional agents, without necessarily trying to kill that last tumor cell, just kill some, cause some inflammation, and give the drugs that we can give during priming and enhance that response, I think we're going to do a lot better. And so I think
that's wonderful. I just have a memory when I was training in oncology myself. People would the number of trainees that would become melanoma oncologists. You would count them on your fingers, and they would be, you'd say to them, why are you going into a dead field? You're going into a dead field where, you have a survival rate of, 5%. And the idea that 50% of their patients would be alive 5 years from the first time they saw them has been transformative. Now, 20, 30, 40% of our fellows in oncology are interested in melanoma, kidney cancer, urogenital cancers, ovarian cancers, and other things. And it's that you've changed not just the world of patients, but you've changed the intellectual heuristic for how we think about, for how cancer doctors think about cancer. And so that's a wonderful testament to your work. Carl, let me turn to you. Sometimes even these powerful therapies that Jim has described and was awarded the Nobel Prize for, that unleash the power of the immune system, are not sufficient to eradicate the tumor. You have to re-engineer the immune system beyond just turning on and turning off of signals that the cancer uses to hide from the immune system or to inactivate parts of the immune system. Tell us a little bit about it, your moment in which you began to use gene therapy to not just activate or inactivate T cells within the body, but take them outside the body, change their biology, reintroduce them into the body, and then potentially cure some cancers. Tell us about that journey.
Thanks, Sid. It turns out your background is similar to mine. I started in bone marrow transplants, where we use a donor and their stem cells and their immune system to treat bone marrow cancers like leukemia. And I started this in the early 1980s, and one of the major complications was graft versus host disease. And I saw, with my own eyes, that graft versus host disease is caused by T cells, the same cells that can also cure cancer. But I saw people die within weeks where the T cells would destroy, the T cells from the donor could destroy a whole liver. A kilogram of tissue could be turned into mud. So that showed me firsthand as a clinician how powerful T cells could be. And at that point, the main issue in immunology came out was HIV/AIDS epidemic. And that actually turned out to be a good thing for me in that it turned out to be a proving ground for using genetic engineering and the cells from a patient to treat a disease. So the first CAR T cells that we made were actually for HIV/AIDS. And we took T cells from a patient who had advanced AIDS and could modify them genetically in a laboratory to fight the AIDS virus and then give them back. And we thought that was just a lab experiment, but we did those experiments, started in 1997, and our first 4 patients on those trials still have CAR T cells 20 years later. Which is something, that's the basis of cell memory of our immune system, is they can survive a long time. And so we're using, this principle of synthetic biology, the idea that, basically put the immune system on steroids. Can we make that immune system better than what it does in a Darwinian way? So can we use gene transfer technology to make it better? Initially, we used it to fight the AIDS virus, and now, then starting in about 20 years ago, also then in cancer. And it turned out the HIV virus itself was a big tool. That that virus could be gutted and no longer cause disease, but it could be used to change the genetic code of someone's T cells. So one of the big lessons, I think, between immuno-oncology, the therapy that you just heard from Jim, is that things come out of basic science that provide then tools later on, the understanding of the immune system at a cellular level, how it responds to antigens, and then how you could use a virus then as a genetic tool. And so we began then targeting T cells from a patient who had leukemia in 2010. And so we took the patient's own T cell into the lab, and then we used the HIV virus to put this CAR molecule in, which stands for chimeric antigen receptor. And basically, it binds to a target on leukemia called CD19. And that first patient that we treated in 2010, still has CAR T cells now a decade later, and he has no leukemia. So it looks like CAR T cells can cure some bone marrow cancers, and that the genetically modified cells can be a living drug, if you will. You could give them, and then they can persist in the body and stay on patrol to fight, what the target you pick. And unfortunately, the target that you pick depends on what tumor you're treating. For leukemia, the kind of lymphoid, it's CD19. But for other leukemias, there are different targets, and now just recently, the commercial approval happened for myeloma, the most common bone marrow cancer in adults, targeting a molecule called B-cell maturation antigen, or BCMA. So the basic blueprint's the same, where the virus is used to introduce the code for the target into the patient's T cells, and then the T cells are administered. Unfortunately, the devil is in the details. Each cancer has different sort of an Achilles heel or a synthetic lethality that we need to identify. And so, the details of, say, glioblastoma therapies will be different for pancreatic cancer and different from, different kinds of leukemia. But I think we're at the dawn of an age now where we have the tools to make, weapons out of our immune system. And it won't just be T cells. We recently had at the University of Pennsylvania a patient infused with macrophages, CAR macrophages, targeting a cancer. And there are trials at many institutions now using natural killer cells, so-called CAR-NK, and your own work, with using stem cells that are engineered. So I think, we're going to see many different cell types used, with these principles of genetic engineering to find Achilles heels in various cancers.
So that's just really an astonishing journey from both your work, from Jim's work and from Carl's work. And I have to say that, the technology produced in my lab is now in, I think, 2 poster sessions and 1 plenary session at the meeting, using, as you're saying, not just T cells, but using myeloid cells as the delivery vehicle to kill cancer cells. So these are cells that, unlike T cells, can enter the solid tumors, penetrate the barriers that some T cells have in some tumors, and then enter those cells. So Myeloid Therapeutics, one of the companies that came out of my laboratory, is also working, like you are, Carl, in re-engineering myeloid cells. And another company called Bohr is re-engineering stem cells. to protect them from the from chemotherapy, so that you can powerfully direct therapy against the leukemia. Acute myelogenous leukemia remains a disease which we are still trying to tackle. Let me turn back to Jim. Jim, this field has moved ahead. You've talked about melanoma patients living for 10 years, 5 years. There are challenges in the field. And one major challenge in the field is identifying which patients will respond and not respond to these very powerful drugs. What do we know about this? And to what extent can we predict which patients respond and don't respond? And to what extent do we know how to figure out how to direct these therapies to patients who are likely to respond versus not respond to these therapies?
Yeah, that is a very big issue. I think that what we know now is that certain kinds of cancer that have a big mutational load, again, because they're caused by, like melanoma, mutations caused by ultraviolet radiation or smoking-associated cancers respond very well. But to really get specificity, we don't really know how to do that yet. There are some tests that, are like for PD-1, measuring PD-L1, some kinds of cancer helps predict, but in others it doesn't. It's not helpful at all. It's not that great, even when it works. What we do know is that, and this is critically important, I think, is that there are signatures that you could see very soon, within a week or so after the initiation of a therapy, that'll tell you if the patient has a likelihood of responding. But nothing at baseline, really, so far. And I don't think there's going to be any single test. We may get better at it. There may be a phenotypic signature that'll help us with that eventually. But right now, there just isn't one. So, we're kind of stuck there. At least.
Do we have any thoughts about how to unstick ourselves? I mean, is it multi-gene therapy? How do we unstick ourselves from this position? One idea that has been gathering a lot of steam is that the capacity of setting up a lymphoid organ, the so-called secondary lymphoid organ, in the cancer cell is highly predictive of a response. In other words, the cancer itself becomes the site for immune activation. Do you think that there's some mechanism by which we could find out relatively early whether a patient is responding or likely to respond to the powerful medicines that you and others have invented that activate the immune system against cancer?
Yeah, I think that, you're right, that finding these lymphoid structures forming in a tumor cell means the tumor cell is done for, because until that point, the T cells have to go to the draining lymph nodes to get activated and come back. But once you get an integrated immune response in the tumor itself, the whole machinery there, the dendritic cells, the innate cells, including the dendritic cells, the myeloid cells, are all there, and they form structures, and it's like, it's Pac-Man. That's the way I like to think of it. The cells can go out, but that's a relatively late signature, but you're right. That is a way of predicting it. I think that what we're going to see, though, is probably a combination of a gene signature from a tumor cell to, say, for example, it doesn't have any mutations in gamma interferon or TNF alpha receptor signaling pathways that would result in death. If they have mutations there, they're probably not going to respond so well. And also looking at the gene signature of the kinds of T cells that you've got in the tumor. And it's going to take a marker on both sides, one from the tumor cell, one from the some, I should say one, but some indication of whether the tumor cell is susceptible to immune-mediated cell death, and then also from the types of immune cells that are there that are going to be able to carry out the killing. But right now, I mean, you are right. The appearance of these lymphoid structures in a tumor are pretty predictive of who's going to respond. But that happens relatively late.
Right.
And tumor growth. I mean, you can find them before therapy, but more often you find them early after initiation of therapy.
Right. Carl, let me turn to you. One of the challenges I would identify two challenges in the field of engineered T cells, and we can talk about myeloid and NK cells in a second. But in the field of engineered T cells, one challenge has always been resistance. So 80 or 90% of patients given BCMA T cells have a brisk response, but unfortunately they relapse afterwards, and then we are stuck with those patients with myeloma. As you know, with myeloid cells, myeloid therapeutics, we are trying to maintain the activity of the CAR T cells and potentially stave off resistance. What do we know about resistance to CAR T therapy? Why does CD19 therapy against acute lymphoblastic leukemia and CLL retain its capacity to keep these tumors at bay, while therapy against BCMA in myeloma is very potent in the beginning, but loses its capacity to restrain the tumor? What do we know about mechanisms of resistance, and what does it tell us about second-generation therapies that will allow us to prevent these?
I think that's probably the central issue in the field, Sid. And any oncologist would not be surprised if you find resistance. And when you look under the hood, unfortunately, the devil's in the details. The mechanisms of resistance that we understand so far, in many cases, are specific for that form of cancer. In the case of CD19, the primary mechanism of resistance with CAR T cell therapy is that the tumor can lose CD19 and then become an escape variant. And we found from some molecular tracing that as few as one cell that can actually lead to the relapse and death of a patient. So you do need to get every last cell if you don't have a broad immune response. And in myeloma, as you say, there's an inevitable resistance. And the mechanisms there aren't clear. I suspect it has to do with the bone marrow microenvironment, because many patients with advanced myeloma, they initially have the bright expression of the target BCMA, but then later it gets dim, but it's not genetically lost like it is in acute leukemia. And we have different mechanisms of resistance in lymphoma, where the tumor microenvironment is more like a solid tumor. And in fact, the checkpoints that Jim has talked about come into play. So in some cases, the resistance to engineered cell therapy could be circumvented and overcome with combined checkpoint therapy. In other cases, where we lose the target antigen, the solution's pretty straightforward. It's an engineering solution of basically making a cocktail of cells targeted against more than one antigen. And that, there are ongoing trials at a number of institutions showing that seems to work, and which is really not different from HIV, where if you use a single monotherapy as an antiviral, you get inevitable resistance due to evolution. The cancer is the same. And I think, unfortunately, with solid tumors, it's going to be much worse. The heterogeneity is there. I think one striking example now is, we know that the primary oncogene in many solid cancers is KRAS. a simple base pair change can lead to KRAS, which can unleash lethal pancreatic cancer or lethal lung cancer. And yet the immune response seems very different in a KRAS-driven lung cancer than it is in a KRAS pancreatic cancer. So unfortunately, we're not going to have this one shoe size fits all. I think we need a really deep understanding of the tumor microenvironment, at baseline and after therapy. Right now at baseline, tumor mutational burden has some predictive value. The tertiary lymphoid organs that you mentioned will be important and so on. But, the main, I think, challenge facing the field for solid tumor are these very cold tumors, tumors that have just no inflammation at baseline. You can't find a T cell, it's a desert. And then, so I think the challenge is for us all is how do we turn those into inflamed hot tumors so that the immune system has a chance.
I mean, I like the idea of inflammation. We've spoken a lot about T cells, but of course, if we think about immunology in general and the immune system in general, T cells are not the only. They're actually late in the immune response. The first responders are myeloid cells, macrophages, and you and I have both worked in parallel to jumpstart an immune response using engineered myeloid cells and engineered macrophages, which have really a different kind of biology. They are not T cells. And similarly, there are NK cells that can be engineered. There are CAR NK cells, but also NK cell checkpoint inhibitors that are coming down the pipeline. So let's explore this area that has not been explored. We've talked a lot about T cells and T cell responses. Maybe I'll start again with Jim. I mean, what do we know of the checkpoints in non-T cells? So, in myeloid biology, Ron Vale and I have been working on activating macrophages and monocytes and infusing those macrophages and monocytes with activated receptors, much like Carl's group has been working. And in fact, at least in animal models, we can eradicate tumors. The amazing thing about this technology is that, once you take these myeloid cells and you activate them, they penetrate the tumors, and then they in turn go and activate the T cells. In other words, you get an effect which is a transference effect. You get a first responder. That first responder sort of like lights the fire. It's a little bit, I often make the analogy, it sparks the fire, and then the T cells take over the fire, or the NK cells take over the fire, and then they continue the fire for a longer time. What do we know about these checkpoints against myeloid and NK cells, and could we overcome them as we move forward? Jim, and then I'll turn to Carl.
Yeah, Doug, you make a very good point. I think I think there's a lot of data that suggests that the particular kind of myeloid cells, macrophages, are there to participate in wound healing and help cells grow, and to some extent, they can protect tumor cells or your immune response and keep them from being, seen by tumor cells. And we know now that at the molecular level, there are particular types of myeloid cells that express not only PD-L1, which is, people think of that, well, that's on tumor cells mostly, but it's also on myeloid cells. The question is, whether they can inhibit T cells, but it seems, at least the response of people with the expression of PD-L1 on myeloid cells does seem to factor in response rates. But also there are other families, like a new molecule that's being looked at now called VISTA, that's found on myeloid cells, never on the same myeloid cells that have PD-L1. So there's incredible complexity there. And then a whole family of molecules, so they're called the LIL-RB, the lymphocyte-like immunoglobulin-like molecules that can also inhibit T cells that are expressed by certain kinds of macrophages. And so we have to learn how to suppress those, or because the myeloid cells are they seem to be plastic, and there's a lot of differentiation states to change the way that they differentiate to where they become less suppressive and more helpful to T cells. But that is a really, to my mind, that is one of the biggest problems that we've got now, is understanding that whole arm of the immune response and how to control it, rather than just concentrating on just the T cell checkpoints. Because you're exactly right, their myeloid cells have a lot of those molecules.
And Jim, let me ask you, we touched upon this very briefly, but we touched upon the possibility of combining. So in other words, you and Carl and me shaking hands somewhere in the middle of America, or in the middle of the world. I don't know where it might be. But what I really mean in particular is that handshake has to do with combining inhibition with genetically engineered T cells. What's been the experience with that? So in other words, can you put in a CAR T cell or an NK cell, engineered NK CAR, or a myeloid engineered cell in combination with the checkpoint inhibitor, and so that we can really move the therapy in a direction that we haven't moved before. What's been done so far, and what's known and what's not known?
Well, there hasn't been a lot done with CAR T cells, but one of my colleagues here at the Allison has done some studies where he's made just expanded monospecific and expanded T cells to an individual antigen on tumors. And what he's found is if he combines CTLA-4 blockade with that, there's antigen epitope spreading. So, if he doesn't give anti-CTLA-4, the cells that he gets back that recognize antigens recognize the antigen that he expanded them and put in. But if he gives anti-CTLA-4, you see maybe up to 6 or 8 different molecules, and he hasn't looked at mutated proteins yet. These are just sort of shared antigens in melanoma and other cancers where you get epitope spreading, and that's one of the problems that Carl was talking about.
Tell the non-technical audience what epitope spreading is.
That means that the problem that Carl was talking about, where the B cell loses CD19 or loses CD20 expression, when those cells when they're killed by the CD19 or CD20 expression, if you can release the checkpoints and make the cells more immunogenic, then you get new T cells coming up that can recognize other antigens in those cells that are not the targets of your original engineered drug. And I think that has got a lot of potential to take care of that problem that Carl was talking about, both with respect to leukemias and more importantly, also, as Carl said, in solid tumors. I think that's going to be even more important.
One of the things that we one of the posters that we have, and one of the things that we're publishing from the work that we've been doing at Myeloid Therapeutics in collaboration with Ron Vale, is that when you send in myeloid cells as your first responders, you see a phenomenon in which we call it cross presentation, and they essentially take the cells, eat them, phagocytose them, eat them, break them up into bits, and then they present them to T cells. And again, it's the analogy that I like to use. It's like a fire starter. You don't need a fire starter to keep the fire going, but you need a fire starter to start the fire. And that's one of the things that and engineered fire starters might be the mechanism by which we can keep the inflammatory fires burning. Carl, we were talking about the idea that sometime in human history, you and I and Jim will meet and shake hands in the middle of the world, because we will learn to combine these therapies, these myeloid and NK therapies with checkpoint inhibitors. And I was asking Jim about sort of what we know and don't know yet about the combination of checkpoint therapies and genetically engineered cells, so that the combination of them can enable us to keep the inflammatory fire against cancer burning even while we move forward into new therapies.
I think that's has huge potential synergy, Sid. As the myeloid cells, since they eat and phagocytose tumor cells, and T cells, basically punch holes in tumor cells. Very different mechanisms of how they can eliminate tumors, and natural killer cells traffic differently. So we need that orchestra. The immune system basically evolved, to handle pathogens, and we want to create a viral infection-like scenario in the tumor microenvironment, and that requires, as you know, and Jim has shown, it requires the orchestra of the immune system, but not one cell will do that. And so I think the future will be these combination therapies. It'll be combinations of different kinds of cell therapies, and it will be combinations with various checkpoints. And then, we haven't talked about oncolytic viruses, which, have a big potential to augment both checkpoint therapy and cell-based therapies. So I think we're at the dawn of that age where the basic issue becomes the regulatory time. Now that we have single agent data with these, how can we combine them and do that efficiently?
So we have about 10 minutes left. Let's talk about both of those things that you brought up, Jim and Carl. One of them is, let's briefly touch on viruses and creating a viral-like environment within the immune system. We're in the middle of a viral pandemic, which, of course, is very disruptive and has devastated human history. But on the other hand, in tumors, the capacity to turn a tumor into something that resembles a viral infection can be something very advantageous. You can take a tumor that was invisible to the immune system and make the immune system, which was designed to recognize viruses, among other things, into something very active. At Myeloid Therapeutics, we've been working on the idea that glioblastomas, for instance, are often carriers of CMV virus, an accidental discovery. And we asked the question, what if we activate an anti-CMV response? Will that anti-CMV response be able to kill the glioblastoma? This was a trial done 10 years ago at Duke, where we rejuvenated it using these myeloid cells and macrophages, and the FDA is forward to all of this. Carl, maybe you can lead off a little bit with the idea of what an oncolytic virus is. Again, genetic engineering, a mechanism to make a tumor seem as if it's a viral infection, trick the tumor, trick the immune system, as if the tumor was a virus. So tell us what we know about oncolytic viruses and where that field is going.
So, this is an emerging area. We know, first of all, that, you have to be clear for the audience on about maybe 10-20% of cancer is caused by viruses. And those are relatively easy to treat compared to the viruses that are caused by other environmental and other DNA, basically, coding mistakes. So if we look at the non-virally caused cancers, we can use a virus as a weapon. If the virus can infect in the tumor microenvironment, it can set up what the immune system has evolved over eons to do, which is clear out the last antigen there. And so we have natural viruses. You mentioned CMV. and we have a really strong immune response. That's a herpes virus, and those can be repurposed as targets. In some ways, it depends if that CMV is in basically the cancer stem cell. So can you get every last cell? But in the general field of oncolytic viruses,
do you need every last cell, or do you think that once you can prime an immune response, a T cell response, the T cell response will take care of every last cell? The fire starter doesn't need to burn every log.
Yeah, so I think that's remains to be proven, but we have and it depends on the cancer. I mentioned this idea of the cold tumor. How do you heat it up? Which basically, one solution you can say is introduce a viral infection into the tumor, and then the immune system will take care of the rest. And I think is certainly happening in many patients. And that and then now we have many different viruses that can be engineered so that they're both safer and more potent to inflame that tumor microenvironment. So I think this will be another one of the pillars of therapies that we use, along with cell therapies and checkpoint therapies will be engineered viruses to accomplish that.
So we've talked about checkpoint therapies. We've talked about not just T cells, but myeloid cells, macrophages, and their checkpoints. We've talked about engineered T cells. We've talked about engineered myeloid cells and macrophages. We've talked about viruses that can recreate the immune response. So, and we've talked about the possibility of combining them in the future to produce a kind of maximal immune response against the tumor. Jim, let me turn to you in the last 5 minutes that we have left and ask you the question about the regulatory hurdles. So, each of these has been tested as an individual therapy, but of course we'd love to learn to understand how to combine them. And many cancer patients feel impatient. They feel as if, we should be doing this now. What kind of regulatory hurdles have you faced? What do you feel the field faces? And how can we advocate and modify some of these so that therapy can move forward much faster than it is today?
Well, I think that you kind of put your finger on one of the problems is the idea of putting in a virus that could infect cells. Oncolytic viruses that are primarily infect cancer cells. They aren't quite that specific as yet, and so there is some possibility of collateral stuff. On the other hand, there is a lot of data out there showing that they can be safe if you inject them into a tumor mass, and then if you particularly, you can eliminate the tumor that they're injected into. And the thing that happens is what we were talking about earlier, the early warning systems of the tumor cell itself responds to having a virus in it as if it's infected, and makes type 1 interferons and other cytokines that help alert the other cells of the innate immune system to get the whole thing going. And they can also, if they lyse the cells, then especially if you add checkpoint blockade, you can get systemic immunity, which could lead to not just destruction. Local tumor therapy, I think, for a long time has not been very popular because the idea of injecting every metastasis, a person has multiple metastases, it's not practical, it's not going to happen. But we know, at least in animal experiments, that if you block checkpoints, particularly CTLA-4, then you can get systemic immunity and lead to distant, rejection of distant, tumors.
Right. There's an old word that used to be called the abscopal response.
Yeah.
Again, it's a reminder that you don't forget history because, people have been thinking about this for a lot of time, and it's an incredible idea that you treat a tumor locally and excite it, and those same cells, the immune cells, then go from the local treatment of the tumor, let's say it's in your left hand, and then go to your right hand. And the same immune cells have been trained against your right the tumor in your right hand because you trained them on your left hand. And, people like Paget and others, used this idea, thought about this idea. William Cooley thought about this idea a lot in, thinking about the systemic response against cancers. Let's spend the last few minutes giving you, both of you, time to say what you're most excited about. Again, just to remind the audience, we've covered a lot of ground. We've talked about checkpoint inhibition for T cells. We've talked about checkpoint inhibition for myeloid cells and NK cells. We've talked about engineering T cells and resistance. We've talked about engineering myeloid cells using various receptors that Carl and I have been working on. We've talked about mechanisms to identify patients who respond and not respond to therapy. We've talked about resistance to CAR T therapy. So we've covered a lot of ground, oncolytic viruses. What's most exciting to you, Carl, as you look forward into the next 5 years?
Well, I am an optimist, Sid.
And Jim, I'm going to ask you the same question, so just be ready.
So I think that, we have a toolbox. It's a rich toolbox now to engineer the immune system and to coordinate it that we didn't have, 20 years ago. So, and we have now investment in this area of immuno-oncology. That was completely lacking before. And what I'm most excited about now is the advent of single-cell technologies so that we can deconvolute the tumor microenvironment and understand these, complex mechanisms of resistance. So I think once we understand those, we'll be able to engineer around them.
Wonderful. And Jim, what are you most excited about as we look forward to the next 2, 5, 10 years into the future?
Well, I agree with Carl that the analytical techniques that we've got now are just going to be essential to figure out how to really, get to the fine levels of manipulating not just the T cells, but the myeloid cells and everything else. But what I would like to see is we know that, chemotherapy, radiation, and things like that can cure certain kinds of cancer. They can, destroy tumor cells, but we really are not using the combinations. Immunotherapy, which, depending on how you look at it, is either the fourth or the fifth pillar of cancer therapy, can work with the others to give them memory, to give them adaptability, to give them polyvalency, and yet, the problem is that most of the therapies, radiation and chemotherapies, have been developed without the experimental systems they've been used in don't have immune systems. They've been used in xenograft models and things where their impact on the immune system is not understood, it's not appreciated. There's plenty of data suggesting that chemotherapies, for example, don't work. Some of them don't work very well if there's not an immune response. And so I think that what we need to do is step back a little bit, try to figure out how to make those therapies work nicely, play nice with the immune system, not try to kill that last tumor cell, just try to wound it in a way that spares the immune system from the damage that you get, so that we can get the synergistic effects that you can of knowing when to apply these other therapies, such as checkpoint blockade, to get optimum effects.
Jim, have you had a chance to meet one of the thousands of patients that have been impacted by your therapy?
Many, yes, actually, yes.
Yes. And Carl, of course, you talked about the first patient. You and I together met Emily Whitehead and talked about this young lady who's now a young lady. She was not when she was first treated with CD19 therapy. I want to end the discussion by reminding people that these are real medicine. This is there's wonderful science behind it, decades of wonderful science behind it. Tim, Carl, Dr. Honjo, and others have led back those decades of science, but they're real patients that lie at the other end of it, and it's one of the greatest things, one of the greatest pleasures in life, I think, is to meet someone whose life you've changed by discoveries made in the laboratory. So I thank both of you, and I thank the Alliance, and also I thank the idea, I would say, very broad idea of gene therapy against cancer, which was a dead idea 10 years ago, but through the work of you and Carl, you, Jim, and Carl, and hopefully my work in my lab and others, Myeloid Therapeutics, Core Therapeutics, has brought this idea into reality and is changing the life of patients. We're infusing these drugs into patients right now as we speak, and that's something that's the most wonderful thing for a medical scientist to know and understand. So thank you again, both of you. Very lively, very thoughtful discussion, and I will turn over back to Barbara to finish this up. Thank you.